management system, UPK Swasthya Kendra, all the facilities are registered in this UPK Swasthya Kendra portal, and the UDSP, Unified Disease Surveillance, all the 12 notified diseases are incorporated in this portal, and the AMS attendance management system, in which we monitor the attendance of all our CHOs and the staff at the next. So the problem, it has been, everybody knows the problem basically, and then we have discussed in an elaborate way, like the HMS portal aggregate, it gives an aggregate data. When it gives an aggregate data, the chances of forging of the data is like if the figure is 10, I can make it as 50, my performance will be better. So there is a human tendency when there is a competition that we need to perform better, and in the process of that, we can do that. In the whole process of data aggregation, the line listing was somewhere missing. We had a denominator, but line listed denominator was not there. And there had been a program-wise parallel surveys for the due list had been done. There was a lack of digital unique ID. So these are the basic problems, and the solution in itself, which went to the key coverage. The answer is the one-time population registry of all the beneficiaries. As it was mentioned that there had been n number of portals, though there had been a common population, enumeration with the Aadhaar saturation, we continued with that, and leading to the continuous updated provisions, collecting the health events and the conditions. Events and conditions both are recorded, like if there is a patient and the event, whatever is the event in that, both are recorded. There had been different portals in the Government of India, which we are incorporating, and they are API integrated also, like RCH, NCD, family planning, and the community surveillance, NDD and anemia, mass drug administration. We have recently incorporated in the February round of the last year, we tried it. Some good results have shown, so we are trying this again. And the Stop Diarrhea campaign, which has been recently launched, we are incorporating this also into this portal this time. Next. So the comprehensive primary healthcare application, what is e-Kavach basically? It's a one-time population enumeration database with family, all the families and all the members of the families. It is a workflow-based system for the field level function. It's like ASHA, then it community base, they work for their village health index register, and the CBAC forms, they take it and it goes, take the family members' Aadhaar numbers, and it goes into the coverage, and from there, from ASHA, it goes to the ANM. Automatically, there is a notifications, the issues, it goes to ANM, then to CHO, and at the state level, directly from the e-Kavach, it can be tracked, and it can go back, the information can go back to e-Kavach cloud hosting also. Admin level, so this helps in the total overall configuration, generate dashboards and reports for further planning as well as monitoring. Then it is the most important point of e-Kavach is there's a single source of truth for the individual's longitudinal health record, Aadhaar saturation enumeration for the health record linkages, due list to facilitate field level workers and the track community level assured service delivery, integration of the digital health system for the population, the register interlinkages. Next. This is just one example of it, like on e-Kavach, there is a dashboard. This is, the ASHA will have this in his phone, in his or her phone, in her phone. All the ASHAs are equipped with the smartphone. We have given them a BSNL CUG with an internet connection. They visit house to house, and when they enumerate each family with the member, including the relationship, it's there. Like this is a dashboard, like it's a Parivar Sarvekshan. If she clicks this icon, then this Parivar Sarvekshan thing comes. And in this, specifically, if she enters into one particular family, like third one, that goes to the family, and then it comes to the name of the family, and further. So she has a track of each family as well as each individual in the family. So there had, like for example, the same person is taking an advantage of, like a female is there, she's a pregnant, she's enrolled as a pregnant, then she's going for immunization, she's going for the ANC checkups, she could be beneficiary of some other thing. So there are different number of benefits she is taking, but they're enrolled in all different portals, in all different platforms. Now, next. Now, what the population is being enumerated in, like for example, with an example I'm showing, just like there are 3 possible forms in the RCH module if we'll take the RCH services. One is an eligible couple. She could be part of the one part of the eligible couple, then she becomes pregnant for her ANC checkup and a child for the immunization. Eligible couple will go for the family planning, it will enter into the e-Kavach. If she is pregnant, she will be tracked for all 4 ANCs to be done. As soon as the ANC is registered, she goes into the e-Kavach. The next stage of ANC will be the delivery, where as soon as she has to be admitted in a hospital, she will be fetched into the Mantra portal, which is again integrated with the e-Kavach. delivery of the child, outcome, and automatically there will be CRS integration of the mantra, and the registration of the birth will be done, and the follow-up for the PNC, as well as the RA services for the child. It again goes back, and the child again is tracked for the RA services. Next. So this is for the RC services for the ASHA. Again, it's the same kind of a module which is given in, which is a little bit more detailed. So this is how we can reach ultimately to the EDD due list of the referred, and we can plan and manage, especially for the high risk pregnancies. It is very important because we know we can plan for the transportation like ambulance, we can plan for the FRU where the person has to be referred, and this will ultimately lead to the NMR, reduction in the NMR and the MMR, because that is the ultimate target of the state we have to perform, especially for the RCH. Next one. This is automatically whatever the information is filled up by the ASHA, it goes to the ANM and the CHO respectively. The system auto-generates all the NC schedules, and they give notifications. And even in the RI module, it gives notifications to the parents that your child is left out for this kind of immunization. So it's a continuous, it's hammering, and then it makes the parents to come to health and wellness center. Next. So this is, same example is for the NCD screening actually, that was for the RCH, this is a module for the NCD services. On the basis of this, there's a CBAC form which they fill, and then they are notified, 30+ population is identified, and after identification of either symptomatic or asymptomatic patient, they are tracked and they are followed up for the treatment, then followed up for the further treatment has been taken up or not, or referral to the next secondary or tertiary sector. Next. So this is another important point is the community surveillance through the eKavach. So it's there are two ways of surveillance, community surveillance as well as a clinical surveillance. In both ways, we track the most important outcome of all these two things is the UDSP portal. If we can go for a disease outbreak. The most important difference with the IHIP portal as well as eKavach is in IHIP, we get just the numbers of it. That this number of patients have been tracked, but eKavach tells how many numbers in which particular location, and then it gives such a response that immediately we go for rapid response team movement, and then we can go for a CAPA. This disease burden assessment, it has helped our state to prevent lots of outbreaks, lots of things to flourish and to go beyond our control. So this has been very helpful for us. Next. So this gives a longitudinal health record of a patient. For example, this Rani Devi is a patient. For example, she is a beneficiary. She is a beneficiary taking care of all these functions. So we can, one click, in the name of Rani Devi, we can have the record of all the different facilities she has taken using this portal. Next. So decision making has become easy. Dashboard has been there. There's a program-wise data analysis is there. We can drill down the options till to the last patient, last individual. Next. So eKavach, the most important impact is a population register with the Aabha. So we have generated lots of Aabhas, and this we have integrated with the Aabha ID. So we know the history of the patient. Even before the patient is referred to the next facility, the doctor is having the history of it, and it is interlinked with all the facilities. All these three we have already discussed. The early outbreak detection is the most important, which has really helped us in controlling our AE and JES impact in the state. Next. So this is just one eKavach ka current status. Like out of total estimated population of 23 crore, we have already enumerated 87%, and total pregnant women 66 lakh, we have enumerated 85% of that. Total children under 5, 2.8 crore. 84 crore, 83 have been done, and total 30+ population, we have enumerated almost 24% of the population. So the impact has been huge. 7.80 crore Aabhas have been geotagged, and the electronic health records have been generated for 1.92 crore, almost 2 crore people. So we have a future. Next. So this was the ultimate impact, because UP, if we improve the services in UP, it's going to have a larger impact on the country itself, and we can drill down to a single person with all the facilities one person is getting. It is still, we are on the process to go ahead and to move in a better form. The main reason is to decrease the out-of-pocket expenditure of the person who is investing. We can study that, as well as to develop a faith in the system of government health system actually, because this will improve the quality in larger interest and in the coming years to go. Thank you.
Thank you, Madam. Now, I would like to invite the Union Territory of Andaman and Nicobar Island to present their best practice on National Tuberculosis Elimination Program.